Hello, my name is Peyton Barfield and I'm a senior majoring in biology. My senior thesis is on the examination of factors related to cesarean sections at a large multi-site obstetrics practice. I would like to acknowledge a grant from the DuPont Foundation for making this research possible. A cesarean section, as defined by the American College of Obstetrics and Gynecology, is the delivery of a baby through incisions made in the mother's abdomen and uterus. Commonly, it is referred to as a C-section and will be referred to as such throughout the rest of the presentation. Although the purpose of C-sections is to save the life of the fetus and/or mother, maternal risks are associated with the procedure, including increased incidences of a ruptured uterus and increased placenta accreta or previa. Placenta accreta occurs when the placenta grows deeply into the uterine wall, whereas placenta previa occurs when the placenta obstructs the opening of the cervix, preventing the baby from progressing down the birth canal. There are also child risks associated with C-sections, such as children developing asthma, which requires hospitalization, and also needing an inhaler. Literature shows, though, that patients are at an increased risk of C-section delivery if they are of increased maternal age, so being 35 years or older, have gestational diabetes or diabetes mellitus, have a multifetal pregnancy as a result of fertility treatments, or have previously delivered via C-section. Prolonged labor, prolapsed umbilical cord, and obstructed labor are also indicators for C-sections, as stated by literature as well. In North America in 2016, C-sections accounted for 32.2% of deliveries, being categorized as overused. This rate has almost remained constant throughout the last 5 years. In North Carolina in 2019, C-sections accounted for 29.1% of live births. Without medical reasons to encourage C-sections, providers also influence the likelihood of C-sections in their patients. Some providers even refer to C-sections as an alternative to spontaneous delivery, despite it being a surgical procedure. For example, in a Spanish study about public hospitals in Spain, unplanned C-sections were found to occur more frequently during night shifts rather than during day shifts when maternal conditions were similar. Performing C-sections during the early morning hours relieved the on-duty doctor from monitoring a mother and fetus throughout the night and allowed the doctor to rest for the remainder of their shift. Similarly, a nationwide survey of Chinese women who had given birth between 2006 and 2007 showed that 57% of deliveries occurred via C-sections, and 40% of those deliveries had no medical indication to suggest the need for a C-section. This occurrence was hypothesized to be a result of China's payment plans for modes of delivery. In fact, C-sections are about 4 times more expensive than vaginal deliveries. So this leads to my research question and hypothesis. I was interested in knowing what were the reasons that C-sections are occurring at an alarming rate. And so my hypothesis is that C-sections are heavily influenced by medical necessity as well as racial disparities. So I did receive IRB and DRB approval for this research. My data consists of de-identified medical records from patients delivering between 2015 and 2020, including patient demographics, delivery method, and complications, as well as provider demographic information from an obstetrics practice here in North Carolina. Patient demographics were operationally defined as patient age at delivery, race minority, and patient-provider minority race match. Patient-provider minority race match was defined as patients and providers who shared a minority race status. For this data set, minority was defined as any race that was not white or European. Medical complications were defined as twin birth, preeclampsia, obesity, preterm birth, pregnancy complications, hypertension, labor complications, racial minority, patient-provider minority race match, and ruptured membranes. These medical complications were collapsed into categories which previously reviewed literature indicated caused an increase in chance that a patient would have a C-section. Furthermore, labor complications included any billing codes related to failed induction of labor, obstructed labor due to unusually large fetus, prolapsed cord, the prolapse of cord during labor, and abnormality in fetal heart rate and rhythm, among others. Pregnancy complications included chorioamnionitis, oligohydramnios, and polyhydramnios, among others as well. A chi-square analysis was done to analyze the proportion of people who delivered by C-section and shared a minority status with their provider through race. A secondary data analysis was done using a logistic regression to analyze the influence of patient demographics on delivering via C-section. In step 1 of this regression, demographics were analyzed as a whole and individually, and in step 2, medical complications were also analyzed as a whole and individually. The dependent variable of the logistic regression was delivery type, so either C-section or vaginal birth. In the first step of the logistic regression, patient demographics were the independent variables. The following medical complications were independent variables in step 2 of the logistic regression. So again, twin birth, preeclampsia, obesity, preterm birth, pregnancy complications, hypertension, labor complications, racial minority, patient-provider, minority race match, and ruptured membranes. Of the entire practice, only 2 providers were male, and therefore provider gender was not analyzed. So there were 4,323 patients whose medical records we had access to. 76.9% of the participants were white or European, 14% were Black or African American, 3.5% were Asian, 0.2% were American Indian or Alaska Native, and 0.1% was Native Hawaiian or Pacific Islander. Participants' age ranged from 15 to 57 years, with the average age being 31.06 years and the standard deviation being plus or minus 5.08 years. 74.6% of participants delivered vaginally, and 25.4 participants delivered via C-section. A chi-square analysis indicated that the proportion of patients who delivered via C-section did not significantly differ by sharing minority status with their provider. Essentially, patients that shared a minority race status with their provider were not more likely to deliver by C-section. And to note, 125 cases were missing in this analysis, as some patients did not indicate their race in their medical records. So for the logistic regression, step 1 showed that demographic variables were significant in predicting who had C-sections. However, race and maternal age was significant, while patient-provider race match was not. In step 2, the medical complications significantly predicted who would have a C-section as well. Specifically, 7 of the 13 medical complications listed above were significant, and of the 7 variables, 6 predicted who was more likely to have a C-section. And in this graph, you can see that the bolded column shows the odds ratio, and this shows the maternal age at delivery, racial minority, twin birth, preeclampsia, preterm birth, labor complications, and pregnancy complications. And these were the 7 variables that were significant with their p-values. And of these 7, 6 of them indicated that patients were more likely to have a C-section. And if you look at preterm birth in the first column, the beta value is negative. And this shows that the patients this shows that preterm birth actually had a 0.3 times less likely chance of delivering via C-section. And in this chart, it's set up the exact same way. However, these are the variables that had no significant impact on delivering via C-section. So implications of these results would be interventions and policies to reduce C-sections and improve maternal-child health. The primary limitation of this study is that the data excludes qualitative data, as only medical records were examined. So future research should focus on different practices with different provider demographics and patient population, and the influence of insurance coverage on delivery mode. And further research should also attempt to include patient and provider qualitative data. So in conclusion, my hypothesis was supported by the results. C-sections are performed because of necessity. C-sections are performed because of necessity for over half of the C-sections indicators in the study, and minority race patients were more likely to have C-sections than their white counterparts. However, more research and policies are required to explore and resolve factors contributing to the higher rates of C-sections in patients of minority races. And then here are my references. And I would like to say thank you to the psychology department for this opportunity, and to Dr. Pravat for answering every email, helping me mine through data, and setting me up for success throughout this entire process. If you have any questions about my research or my results, please feel free to contact me via the email listed above. Thank you all and have a wonderful day.